Good evening, everyone, or good afternoon, I should say. My name is Wendy, and I'm a Community Education Coordinator for Boulder Community Health. I'd like to welcome you to today's lecture on advanced treatment for Parkinson's disease. I'd like to go over the format for this lecture. Mr. Jim Morgan and Mr. Scott Ryder from Parkinson's Across America will speak to us first. They'll do a short presentation about their mission in raising awareness of Parkinson's disease and their experience with Parkinson's disease treatment. Then Dr. Kara Beasley will present for about 30 minutes. Afterwards, we'll use the remaining time until 3:30 for questions. Please do type your short general question in the chat box below the video screen on your screen, and we'll do our best to get to it if time allows. So on behalf of Boulder Community Health, I'd like to introduce today's speaker, Dr. Kara Beasley. Dr. Beasley is a board-certified neurosurgeon and one of the only dually credentialed neurosurgeon bioethicists in the world. She received her Doctor of Osteopathic Medicine from Midwestern University in Glendale, Arizona, and went on to complete a general neurosurgery residency at the Philadelphia College of Osteopathic Medicine. Dr. Beasley has also completed fellowships in stereotactic radiosurgery and functional and restorative neurosurgery. Dr. Beasley sees patients at Boulder Neurological and Spine Associates at Boulder Community Health. So please welcome our speakers today, Dr. Beasley, Jim, and Scott.
Good afternoon. It's a pleasure and honor to be here. A special thanks to our friends at Boston Scientific who are sponsoring part of our trip, Parkinson's Across America. I'm privileged to be here with my good friend Jim Morgan, who you'll hear from in a couple minutes. But I want to talk to you about life with Parkinson's. I've had Parkinson's for 16 years, and so many people, I think, when first diagnosed, think it's the end of the world, the end of the rope. And I want to talk to you about making a choice, choosing to live well with Parkinson's disease, because both Jim and myself do think it's a choice. Who are we? Jim came up with this line. He likes to say we're just two ordinary guys with Parkinson's disease trying to make a difference, or like somebody here in attendance said a little bit ago, we're two old ordinary guys trying to make a difference. I mentioned earlier I've been diagnosed for 16 years, and like most of you out there that have Parkinson's, I realized that I had symptoms long before that. Jim is a retired attorney, and we share something in common. We both have been diagnosed about 16 years ago. So let's kind of get into the meat of things. What's our goal today? We want to give you hope and encouragement. If you're like us and have Parkinson's disease, you might be a care partner, you might be a relative, a family member, a friend, but hope and encouragement is really the theme of Parkinson's Across America. I mentioned earlier, when you hear those words, you have Parkinson's, it does take your breath away, but it's certainly not a death sentence. And you're going to think this sounds odd, but I would argue that it's an opportunity. It's an opportunity to make a difference. I don't want to suggest that living with Parkinson's is easy, because it presents great challenges. But I think we all must come to the realization there are some things in life that are beyond our control. And the fact that if you're diagnosed with Parkinson's like I was, it's not something we chose, it's beyond our control. And I think the earlier in our kind of journey with Parkinson's is that we accept that and understand that, I think the healthier we'll be. I'm not suggesting, again, that that's easy. So Parkinson's disease is a new way of life, and Jim and myself think that there are 4 specific factors that really make life better if you choose to follow these factors: attitude, exercise, strategy, and involvement. So I'm going to roll through a couple of these, and then I'm going to turn it over to Jim in a little bit. If I had to pick one of these 4 items that I personally think in my journey has been the most important, I would argue it's attitude. Attitude's something I can control. When you have Parkinson's, there's so many things you can't control. So people often say to me, they'll say, "Hey, Scott, what's it like to have Parkinson's disease?" And for years, I tried to think of a good way to explain that. So this is going to be kind of odd. You see on the screen, there's a picture of a commode. Study that picture closely. Look in the windowsill. There's a roll of toilet paper. Now, this was a a VRBO I was staying on with a group of friends. We were doing a bike ride across the state of Ohio from Cleveland to Cincinnati. And we stopped here, and I thought, you know what, that really represents what Parkinson's disease is like. That's just not right. Everything's kind of off in that picture. A roll of toilet paper should never be on the windowsill, right? Well, Parkinson's is kind of like that. Everything's sort of off. Each day's a little different than the other day. And that's really the best way I could describe what it's like. I wonder, have you ever heard somebody say, I'm not going to be defined by X? And that could be anything from cancer to diabetes to something that happened in their past. Well, what Jim Morgan and Scott Wright are here to tell you that we're just the opposite. We decided early on that we were okay being known as the guys with Parkinson's disease. Now, you may think that's kind of strange, but let me share why we said that. But I want to tell you first, I'm not going to kid you that when I received that word, I was sad for a minute. I will tell you, I cried. I stepped out on the sidewalk with my wife, and she said a few words I'll never forget. She said, it'll be okay. And that was it. I flipped the switch and I said, you know what, I'm going to use this to help other people with Parkinson's disease. And I've come to realize that everybody has challenges in life. It may be financial, it might be relationships, it could be with an employer, but everybody has challenges in life. So our challenges with Parkinson's are really no different than other people have. And I also knew that people would be watching. How is Scott Ryder? How is Jim Morgan? How are we going to handle those challenges? So I want to tell you a little secret, and it's really not a secret, but helping others helps us too. In fact, sometimes I feel guilty. If I do a presentation or reach out to somebody or have coffee with somebody that's newly diagnosed, I feel like I get more from it than they do, and I almost feel guilty for that. And I think that's something that each of you that are listening to could kind of grab onto. The more you help others, I think the better you're going to feel about yourself. I'm going to spare you the song bit. I'm going to share with you kind of my age group and my genre of music. You might remember a group called Foreigner, and they played a song called Head Games. I won't sing it for you because I don't want to end this meeting prematurely. But that's kind of the tune, if you remember that. So I think one of the ways I've coped with Parkinson's is I call it head games. Now, my oldest daughter is a psychologist. She said, Dad, would you stop using that terminology in your presentation? It's called cognitive restructuring. I said, yes, ma'am, thank you. I call it mind games. I think there's certain things you really just have to accept that I've had to accept. Having Parkinson's is not the life that I imagined. It's not the life that I thought I would ever live. But the sooner that I accepted the fact that I wasn't going to live life the way I thought I was going to live, the better off I was going to be. I can't think too far in advance. I don't know what tomorrow's going to bring. I don't know what the next 5 minutes is going to bring. So you know what matters the most? And I say this to every one of you that are watching this. It's this minute, this moment, right now that we're spending time together. That's the most important thing that we can all grasp onto. There's no value in thinking too far ahead. There's no value in thinking, am I going to be able to walk? Am I going to lose this ability to do this or that? It's right now. It's this moment that counts. So on the screen, I'm not sure why, but there's 4 slides. I didn't mean it to do that, but when you have Parkinson's, things happen like that. So I'm going to see if somebody can come up here and help me. She says she's happy to help. I'm going to talk about that in a minute too. I'm not sure how I did that, but that's great. Thank you. So let's go to the next slide. I think it's helpful to have a sense of humor. Jim despises my jokes, but there are a few Parkinson's jokes. I always say, do you know what's black and all over the place? Does anybody know? My signature. I think that's kind of funny. I'm a graduate of The Ohio State University, and I'm being more serious now. I don't know if you know this, but they have a school of veterinary medicine there, and they are doing a bovine study, and they've realized that cattle, bovine, have Parkinson's disease. They call that beef jerky. I know. It's pretty good. So I think it's important to have a strategy, and I keep referencing Jim, who you're going to meet in a minute. He had a very important strategy, but I think it's important that each of us have our own strategy. There's a couple things we need to know that we know if we have Parkinson's. Many of us tend to avoid social situations, and there's plenty of research out there to show you that people that don't avoid social situations, people that are more social, really battle Parkinson's a lot better than people that tend to withdraw. So what I'm encouraging you to do is, if you're one of those people that tends to seek seclusion because you're worried about what somebody thinks about their trimmer, or you're worried about your speech, or you're worried about drooling, things that I've all done in front of other people, don't be that way. Get out, be amongst people. You're going to benefit from it. But have a plan. So if you're going to a social situation, think about your care partner. They want to be with you. They love you. They love you unconditionally. The fact that you have certain things that present themselves like a tremor doesn't cause embarrassment to your care partner. Seclusion's not good for any of us. People care about you. How many times does somebody walk up to you and they'll say, my last name's Ryder. They'll say, Ryder, how are you doing? No, really, how are you doing? So I think it's important to demonstrate that we can live well with Parkinson's disease. I say have a pre-planned introduction. So this may seem corny to you. If I walk up to somebody, I shake their hand, I make them hold my hand until they feel my tremor. I said, hey, my name's Scott Ryder, I have Parkinson's disease. But I said, don't worry, it's not contagious. They laugh, I laugh, and the pressure's all off. Think about the type of glass you're going to hold. I don't like those long stem glasses. That's just not comfortable. If you're going to a party or a social situation where there's going to be small food items, you don't want to pick it up, eat before you go. Nobody's watching whether you eat at the party or not. I think we think people observe us more than they do. Scout out the room before you get in there. I look at a room and I avoid certain narrow pathways, or I avoid certain chairs, things of that nature. Use the bathroom before you go. It makes it so much easier before you go to a social situation. And you know what? Never hesitate to ask. I was in an airport in Seattle, Washington, and an airline representative walked up to me and said, sir, could I help you? I said, no, I'm doing great. And then I stumbled over a few more chairs. She said, sir, could I help you? I said, no, I'm doing great. She said, sir, please, may I help you? And the next thing I know, I was in a wheelchair. It was kind of cool. I was filming myself going through the airport with this guy pushing me on a wheelchair. I've asked people while I'm biking to help me clip in. I clip in on my bike because I've asked people to help me unclip. People are willing to help. If you don't know what a movement disorder specialist is, talk to somebody that can help you understand what a movement disorder specialist is. Find somebody that's had Parkinson's for a while. This is my personal opinion. It doesn't represent the opinion of anybody else, but if you have Parkinson's, I want to see the person that's best equipped and best trained, that has the most knowledge to help me battle this disease. It's not a simple disease. We know that only 9% of people with Parkinson's see a movement disorder specialist. We also know there's a shortage of movement disorder specialists. And that's something that a lot of organizations are working to change. So we talked about choosing well to live with Parkinson's disease. It's a choice. Now let's talk about exercise real quick. I think exercise is as important as medication. I'm not suggesting that we stop taking our medication. I would never suggest that. Total Health Works is one of our sponsors for Parkinson's across America. There's Rock Steady Boxing. There's so many great programs all around the nation. But exercise daily. I'm told that getting your heart rate up, elevated is really important. You know, you can hire a personal trainer that'll come to your house to help you exercise. There are so many options with exercise. A friend of mine invented these things called Zitty sticks. If you've never heard of them, just Google it, Zitty sticks. I'm going to spare you the video because it's old, but if you have any challenge with walking, with cadence, stride, these things are amazing. I have some personally, and it helps you develop a cadence and get proper arm swing. My really point being is that there are so many tools available for people with Parkinson's.
I'm David Zid, and I'm here.
And that's all we're going to see of David Zid, but he's the inventor of Zitty sticks. Find a type of exercise that you enjoy. Jim, he likes yoga. I like biking. Jim likes boxing. I like to try to run. I can't really run anymore. But find something that you really feel good about. The reason I like biking is it allows me to move. And Parkinson's is a movement disorder, so I feel free. I often say when I'm on a bike, I feel like a cowboy on a horse. I can just go, and that's a great feeling. So Rock Steady Boxing is really popular. I kind of like boxing sometimes because it allows me to get some of my frustrations out. But it's about movement. It's about exercise. It's about camaraderie, spending time with other people. Set a goal. Put it in writing. It's only a goal if you put it in writing. So exercise is important. Involvement. I probably have received more benefits more knowledge, more information from being involved with Parkinson's organizations than the average person because I'm heavily involved. So if you're not involved, get involved. This meeting is coming to you from Boulder, Colorado. There's so many great organizations around here. There's the Davis-Finney organization. There's tons. There's the Parkinson's Foundation. But what happens when you get involved is you meet people that inspire you. And the Parkinson's world is filled with lots and lots of inspiring people. And you find out that living with PD is a way of life. So I'm encouraging you to immerse yourself in the Parkinson's world. Join a support group. And I don't want to hear that excuse, I'm not going to the support group because all there is a bunch of old, shaky people in there. I hear that all the time. Go, because you're going to help somebody else, which is going to help you. It's a place to get encouragement, to give encouragement, and it's a place to gain knowledge. So there's lots of great organizations within the Parkinson's community. There's the Michael J. Fox Foundation. There's the Davis-Finney Foundation, the Brian Grant Foundation. There's the Parkinson's Foundation. I could go on and on and on. So Parkinson's across America, we've chosen to align ourselves with the Parkinson's Foundation. And they're all about making life better today. And I mentioned earlier that today is what's important. Now, we talked a little bit about strategy. I'm going to turn the microphone over to Jim. And Jim's going to talk to you about a strategy decision he made as far as managing his health and his decision to have DBS. And I think you'll find it interesting. Jim's story is amazing. It's inspiring. And the before and after, it's a complete makeover. I think you'll find it pretty encouraging. So, Jim?
Thank you, Scott. Yeah, we thought it'd be useful for me to describe a little bit about my experience with DBS and kind of my experience with Parkinson's leading up to it. It turns out that I did have DBS surgery, and I celebrated my second anniversary on Friday. I had it done at the University of Miami. The implants were inserted on September 16th, and the device was inserted on the 23rd, and that says 2022, but it should be 2020. You know, I tell this story about kind of how I decided that I had Parkinson's, or it was decided for me. I had gotten a call from a client on a Thursday night and asked me to be in Santa Monica, California from Miami the next morning by noontime, and said, you know, he promised me that I'd be home by Tuesday. He just wanted me to go out and close the deal. And it turned out that after 6 weeks on the road, from Santa Monica to LA to New York, ultimately to Miami, it was probably one of the worst deals that I'd ever done in my life. But by the time I got home, I couldn't sign my name, I couldn't write my name, and I couldn't type on the computer. And so after a long story, my experience was probably the same as anybody else's. I ultimately found my way to a neurologist, and he asked what I was there for today. And I said, you know, I think I have that secretary's disease. I think you call it carpal tunnel. He laughed, and I laughed, and he said, no, you had Parkinson's disease. And that was pretty much the way I was diagnosed. So my Parkinson's progressed pretty slowly in the first few years. And my experience was more with rigidity or bradykinesia than it was with tremors. So I was able to live with it. But I ultimately started trying all the different meds and all of the ugly side effects that came with them. You know, the headaches, the nausea, the drowsiness, the brain fog. I had it all. And I ultimately had to switch to carbidopa, levodopa, different times, Cinemets to Levo. And that was necessary for me to continue to function at work. And the more I took, the more severe my dyskinesia got. And I think that was when it really started to become the downfall for me. To counter that dyskinesia, I started taking amantadine, and that caused drowsiness. You know, everything builds one on the other. And I knew that that was a problem one morning when I woke up. I had bumped into the lady in front of me at the red light, having fallen totally asleep. But at the time of my surgery, I took probably 8 to 10 Cinemet pills a day. I wore the highest dose of Nupro patch, the 24-hour timed release dopamine agonist. and that causes all sorts of different things. The extended release carbidopa levodopa I took at bedtime just so that I could wake up in the morning without severe dystonia in my feet or cramping. And I took the extended release amantadine for dyskinesia. But the things that bothered me the most were, I think, the brain fog and the drowsiness, and they began to severely impact my ability to work. I had difficulty concentrating. As a lawyer, I would review documents that were hundreds of pages long, and I'd get to the end of a document and think about something at the beginning that I wanted to go back and look at, and I'd start flipping backwards only to forget what I went looking for to begin with. And so concentrating was a real problem for me. And as I mentioned, you know, the drowsiness. I can remember falling asleep on several occasions in conference calls, one of which that I know of, it was mid-sentence and I was the guy talking. And so I knew that that was going to be a problem. But ultimately, the biggest problem for me was dyskinesia. And I wanted to share with you me before deep brain stimulation surgery. This is a video that Scott and I made for an event that we're going to host in California that year. Just to give you an idea of my dyskinesia.
This is Jim Morgan.
And this is Scott Ryder.
Together we are
The co-chairs for the inaugural Parkinson's Foundation Volunteer Leadership Summit.
And if we can remember, we have a couple of important reminders to share with you. Number one, dress as casual.
We want you to be comfortable and want you to relax and take this as an opportunity to meet as many people as you can and form relationships around the country, because that will make us a stronger foundation.
Number three, or is it number two? I don't remember. But
But anyhow, that's me before, this is me after. And you know, all I can say is that my life has been changed because of the DBS. And I've reduced my meds from the equivalent of 30 pills a day to a very low dose of Rytary 4 times a day. And all of that brain fog and dyskinesia are gone. And all of that's thanks to the DBS surgery. You know, people say, what's the one thing, the advice that you would give? And everybody always says, I wish I did it sooner. And it's totally true. It was not the horrible experience that I was anticipating, and it's much easier than you could have ever imagined. You do have to be patient with the post-surgery programming, because your body needs to adjust to the new stimulation. Your body really, it's something totally foreign, and you have to understand what the stimulation is and isn't doing for you. When I first was diagnosed first programmed, I couldn't ride a bike because I couldn't keep my foot on the pedal. And I thought that that was because there was not enough stimulation, so I'd crank it up on that side, only to realize that I was causing the dyskinesia with too much stimulation. And that's the kind of thing that you have to learn as you experience it. But you've got to be realistic in your expectations. Several friends have come out of DBS and not taken a single pill since. I'm not sure that that's very realistic, but certainly my experience has been that you can significantly reduce the medications and all of the horrible side effects that go with that. So I'm going to turn it over to Dr. Beasley and let her talk about what they did to me, and see if you can't do a better job explaining than I have. Thank you.
There we go. So first of all, let me just say that I am absolutely honored to be on the stage with these two gentlemen. Do you know that they are literally riding bikes across the United States with Parkinson's? Like, I can't, well, I can ride my bike a little bit, but I couldn't imagine doing what they're doing. And these guys have Parkinson's. It's so inspiring. And so really the message is that deep brain stimulation is one of those tools that allows you to do exactly what that goal is, which is to live well today. every day. You don't know if you're going to have tomorrow. We don't know if we're going to cure Parkinson's, but what we do know is that we have this moment, we have today, and what DBS allows folks with Parkinson's to do is live better every day. So what is Parkinson's? About 10 million people worldwide have Parkinson's, and it's a progressive neurodegenerative movement disorder. It's marked by a decrease in dopamine in the brain. That's why they're talking about taking these dopamine agonists. That's what those medications are. We don't know what causes it, and in the United States, there are approximately 1 million Americans living with Parkinson's, 10 million worldwide, and about 1% of everybody out there in the United States will be affected over the age of 55 with a diagnosis. So that's a good number of folks. You probably know somebody with Parkinson's, and maybe you know somebody with deep brain stimulation too. So the symptoms include rigidity or stiffness, some speech, quieting of speech, slurring of speech, tremor, slow movements, also known as bradykinesia, shuffling of your gait, freezing of the gait, a little bit of postural instability can occur. Those are the known motor symptoms, the things that everybody sees on the outside. There's also some non-motor symptoms, like decreased sense of smell, which can occur 20 years prior to the onset of some of the motor symptoms. Insomnia, or something called REM sleep disorder, where folks act out their dreams. Depression or disturbances of mood. Bladder or bowel dysfunction. Pain from being stiff and slow, chronic fatigue. So there are some non-motor symptoms as well. It's not just the tremor, the stiffness, and the slowness, although that's what we're going to focus on with deep brain stimulation. So there are a lot of treatment options for Parkinson's disease, and surgery, deep brain stimulation, falls somewhere in the middle. The first is exercise, and I cannot emphasize enough, and that's why it's so wonderful that Scott talked about it and that these gentlemen are riding across America, because what we do know is that without a doubt, exercise is so important for folks living with Parkinson's. The next is medications, and there are a lot of series of medications. I'm not a neurologist. I don't prescribe medication, so I'm just going to say that if you do have Parkinson's, finding a movement disorder neurologist near you who knows what the different classes are, the different interactions, what medications may be best for you and for your situation is critically important. The next are ablative surgeries. There are some ablative surgeries out there. We used to do them a long time ago. We've started doing them again. The problem with ablative surgeries is that when you burn a hole, ablation, you're burning a hole in the brain. I imagine, like, dig a hole. All right, I actually wanted it 2 millimeters to the left. I actually wanted it smaller, not bigger, except I want that happening deep in the brain. Good luck with that, right? So it's not that they're not effective, it's just that they're not our first choice. What would be our first choice surgically is deep brain stimulation, which has been around since 1992 for essential tremor. So we've got 30 plus years of experience in deep brain stimulation worldwide. This is not experimental. I call it minimally invasive brain surgery, sort of off the cheek, but Jim may tell you that in fact it really is that. And then the next most important thing, and here's the thing. Folks who have deep brain stimulation or a surgical procedure to help treat the symptoms of Parkinson's, the reason we're doing that is to help you move better so that you can do things like participate in neurorehabilitation and in exercise programs, because that's what's going to make your life better at the end of the day. So there's no question that there are some changes in the quality of life as Parkinson's progresses. And again, it's generally slowly progressive, but on multiple different scales that look at quality of life and different measures of quality of life, we can see over time, we're looking at 9 to 12 years at the end of that, you get a decrease. Medications initially manage Parkinson's very well. So there's this sort of band in which there's a threshold that the medication must reach to help treat the tremor, the stiffness, the slowness. And then that reaches a point where there's something called dyskinesias, where the medication actually induces those abnormal movements that you saw on the video previously. And early in Parkinson's, it's a pretty wide window in which medication works before dyskinesias are reached. But as Parkinson's progresses from moderate to then advanced, you require more and more medication to get a dose that will work for your tremor, your stiffness, your slowness, and then that threshold whereby it works for your tremor but then induces dyskinesias becomes lower. Medication also begins to wear off sooner. So as Jim talked about, he started taking a couple of doses, and by the time he was done, he was taking it 8 times a day or 30 pills a day. So those doses were becoming closer and closer together. They were becoming less and less predictable. And that's really where deep brain stimulation comes in. So let's talk about DBS for a minute. The first thing to do is to explore your options. Make sure that you know what options are available to you. Then see somebody about deep brain stimulation. And it doesn't always have to be that a neurologist or a primary care doctor recommends it. A lot of times folks just show up in my office and say, hey, talk to me about this. Now, it may not be the right time for them surgically, but there's never a bad time for me as a physician, as a surgeon, to sit down and have a serious, in-depth and important conversation about what one might expect, when might be the right time to discuss DBS. Then you undergo surgery, and then that for the leads, the wires that go in the brain. Then you implant a generator or a battery in the chest wall, and then you move on to programming, which is the lifelong portion of deep brain stimulation. So really what we're delivering is a high-frequency electrical stimulation to very, very specific deep structures in the brain. And for Parkinson's, those structures are the STN, or subthalamic nucleus, or GPI, globus pallidus internus. Essentially what it is one might think of it as a pacemaker for the brain, or applying stimulation that overrides the abnormal activity going on in the electrical circuits of the brain to bring it back into a better state. So there are many professionals involved in evaluating deep brain stimulation. Neurology is critical. Neuropsychology is very important, and so we're going to talk about a window for deep brain stimulation, and neuropsychology is there to look at the cognitive effects, the depressive effects that Parkinson's can have, because if one has too much dementia or too much depression, deep brain stimulation can sometimes be harmful, so we have to catch you in the perfect spot. Rehabilitation. My deal with my patients who I implant for Parkinson's is that I'm going to put this in you, but that means then you have to get out there and you have to go to your LSVT. You have to go to Dance for Parkinson's. You have to go to Rock Steady Boxing. You have to hop on your bike. You have to move. We're letting you move better. Now you have to move because that's what's going to give you your quality of life at the end of the day. And then there's psychiatry and nursing. So it's super important to know that you actually have idiopathic Parkinson's disease. There are a whole lot of things that look like Parkinson's that are not. And so it's really important to know that you have true Parkinson's disease as opposed to Parkinsonism. And optimize your medications. Then review the potential risks, benefits, and side effects. You really need to know what you're getting into if somebody's going to operate on your brain. Review your mood and cognition. That's that neuropsych portion of things. And then know what your strengths, your weaknesses are, and always work to your strengths. That's part of that attitude. That's part of that getting there and having a goal. And then really understanding what your long-term goals and your long-term care is. So some predictors of potential benefit are if you respond to the dopaminergic therapy, Sinemet, carbidopa, levodopa, whole bunch of them, but the generic is carbidopa, levodopa. The response to that, we like to see about a 30% response with the exception of tremor. If your tremor doesn't get better with carbidopa, levodopa, so what? We can make it better with DBS. So that's why we do something called on-off testing, where you come in off of your medication. We want to look at how bad you look with Parkinson's. Then we want to give you your medication, and we do that motor subscore again, because deep brain stimulation works for the following symptoms: tremor, stiffness, slowness, sometimes freezing. So that's what we're looking at when we do that evaluation. We'd like to see a 30% improvement. That will predict that you will do well. And then selecting the right patient, somebody with appropriate expectations, appropriate goals, putting the lead in the right spot. That's where I come in. That's what my specialty is. We're talking about spots that are about the size of an almond deep in your brain, and in that almond there are multiple parts, and I need to be in that exact spot. So a half a millimeter in one direction or another is a big difference. So somebody who's really accurate, putting the lead where you want it to be, and then after that, somebody who's really good at turning the thing on and programming it so that it specifically treats each patient, that personalized programming therapy. So that window that we talked about is when medication becomes less effective but hasn't stopped working, and when there is not significant cognitive dementia or severe depression. The worst thing that can happen for me is somebody comes to me and they say, well, it's brain surgery, so I'm just going to wait until that's my last option. In fact, that's not true. In fact, it can be too late. And it's heartbreaking to have to say to somebody, you know, look, if I'd seen you 6 months ago, a year ago even, a year or 6 months ago even, we probably could have implanted this and helped you, but now you're no longer a candidate. So this is not a treatment of last resort. It's also not a treatment of last resort because, as I'm going to show you with the data, you live well and you live better with deep brain stimulation than you do with medication alone. So why wouldn't you want to live well and better earlier? And we have a lot of data now that shows that it is safer to implant earlier in Parkinson's than we originally thought. So you can expect tremor reduction, increased mobility, medication reduction, and here's the key, overall improvement in quality of life. And that's what we're here to talk about today, right? Living better today with your Parkinson's. Now, there are some risks and adverse events. There's a small risk of hemorrhage, small risk of infection, small risk that it's not in the right spot, which is why we oftentimes do this awake so that we know exactly where we are. Risk of seizure or stroke. All of these are very, very small risks when it comes to the benefit that one could achieve. I'm a bioethicist, they mentioned that, so this is super important. No matter where you are considering deep brain stimulation, make sure that your goals are going to be met. For instance, deep brain stimulation doesn't work for balance. So if balance is one of your goals, and you don't understand that your balance will not improve, then you're going to be unhappy, even if you can now drink from a coffee cup and hold the newspaper without rattling and move better. Even though you're feeling better, if your goals are not met, you will not be happy. So make sure that you have reasonable goals and expectations. It's important that you have family and social support because you're going to have to go back and forth to programming appointments, and it's surgery. You need somebody to stay with you. And you want to have your family on board with all of your treatment. Your care partners are so important overall in Parkinson's, but when it comes to surgery. So it should only be done on the right person for the right reasons, and that is critical in my mind. So where do we stimulate? We stimulate those areas called the STN and the GPI, and they're really small. So being accurate is super important. The surgical technique, we use very sophisticated imaging and software that allows us to hit precisely where we think we're going to be. And then because I do this surgery awake, I listen to every single spot in the brain all the way down because different parts of the brain sound different so that we're sure that we've hit the right spot. We use what's called stereotaxy. So you either use a frame, which is that top picture, or a frameless system, which is the one sitting in the hand, to allow us to get from the outside to the inside, essentially using Cartesian geometry to get there. We place the electrode or the wires, one on one side, one on the other, and then in a separate surgery, connect those to a battery. People call it a battery. It's technically called an internal pulse generator if we want to get fancy about it. You know, as doctors, we have to use big words to justify our educations. But that battery or IPG in the chest wall, it's all buried underneath the skin and can be programmed remotely. Not remotely, can be programmed non-invasively. Eventually, it's going to be programmed remotely. That I predict. So looking here is that microelectrode recording, what we hear in the brain as we come to the right spot. That STN, that big blue line in the middle, is what I'm looking for and listening for in surgery. We move your arm around. We listen to it. We hear those cells fire so that we're sure we're in that tiny spot in that almond deep in your brain. Then we put the wire in. When we put the wire in, we actually test. I watch your tremor go away. I watch you in surgery move faster, move better, have less tremor, so that we are sure that not only do we have it in the general area, which is precise, but in the exact right area, very precise, looking for any programming side effects. We then, you go home, you come back, you have the generator, you go home again, that's an outpatient procedure, the generator, and then you work on programming. And programming is really where the rubber hits the road. And you start physical therapy, occupational therapy, speech therapy, and then long-term we monitor the hardware every now and again, and by every now and again, every 9 to 15 years or so, depending on which battery you have to have a tiny surgery to have it popped out, popped back in. I joke, if I had a zipper, I would love to install a zipper, but they won't let me. So, anyhow, so the rehab goals are functional mobility, gait transfers, functional activities of daily living, improved posture and balance and speech, strength, mobility, preventing aspiration, bowel or bladder continence, all of these safe environments, all of these things are your goals after you have this implanted. So programming is super important because we need a precise control of that stimulation. And there are a couple of different kinds of systems out there, and the newer systems, that advanced part, are these leads that are very directional. There are circles at the top and the bottom, and the circles provide a ring of stimulation. But the two middle contacts on that lead are cut into thirds. And those thirds can then drive stimulation to different parts of the brain so that as Parkinson's advances, we can increase stimulation, driving it away from an area that might be a side effect. All stimulation side effects are from stimulating areas around this almond in the brain, and push it towards the effective areas so that we can be more effective long-term in stimulating. The other advance is that, for instance, the Boston Scientific lead has something called multiple independent current control. In electricity, here's a little physics lesson for you. You send electricity down a wire. If you send it down a wire, and it's just a single wire, it's just going to go to one spot. If you send it down a wire and it splits, there's a splitter at the end, and it splits, theoretically, you can say send 30% here and 70% here. Can't do math today, apparently, but what really happens is the electricity is going to follow where the path of least resistance is. That's basic physics. And so even though you say 30 here and 40 here to give us the best, you might end up with 50 here and 50 there because the tissue resistance in those areas is so different. So the fact that each one of those leads, each one of those contacts has its own independent current is critical in getting you the most precise stimulation out there. And that's what that multiple independence, like turning on one light switch versus being able to turn on 2 or 3 of the light switches below. And that's what we were talking about here. So then how does my doctor know which one of those 4 sets do I pick? Well, every brain's different, and so that's why we test in surgery, that's why we do it awake. And so programming your device is a really important step, and it can take some time, as Jim said, and it can require some practice. One of the other advances that we have is something called image-guided programming. And so if you compare programming to sort of a treasure hunt through the forest is your brain, and so this treasure is the sweet spot inside of your brain, right? And so in traditional programming, it's dark, it's night, you don't have a flashlight, you don't have a map, you don't have anything. So you're sort of feeling your way around. Let me try this, let me try that, let me try that. It can take a lot of time. And because every brain is different, it can be very difficult, and that's why you need a good programmer, thing one. And thing two, you really need somebody who has that time. With image-guided programming, where we take images from surgery and where your lead ended up, we can create a personalized map. So you can send that person out to find that treasure. Instead of in the dark, they're finding in the daylight. They know where to go. They have an X marks the spot. And so it's designed for efficiency. And so you can cut that programming by about 56% with image-guided programming, which is great for folks when the programming sessions can be long and they can be draining and you have to come back and forth. And so the image that you see on the left is the map, and the treasure is finding that exact spot or that exact perfect programming for each person, taking the trial and error out of it. So we can personalize it to your anatomy. So outcomes show that there's about 6 hours, plus or minus 3.8 hours increase in that on time, and that time where you're getting effect like you would from your Cinemat, getting effect with your tremor, your stiffness, your slowness. And this was done at 23 sites, randomized around the country to find this exact purpose. Here's some other evidence. What is the general data on DBS? Does it work? Well, I mean, Jim just told you it did. I'm telling you it did. But, you know, this is New England Journal of Medicine, Journal of American Medical Association. I mean, these tiny little journals nobody ever reads, right? Actually, these are really great studies. So the primary evidence is spectacular. So if you look, I love these graphs because everything above the line is an improvement. Everything below that line is a decline. Everything in the dark blue is deep brain stimulation. Everything in the bright blue is medication with nothing else. Without a doubt, you can see at every single one of those measures in both of those studies, both long-standing and recent, deep brain stimulation did better than medication alone. Better than medication alone. You say, well, what about that guy down at the bottom, that guy right here and right here? You know what those are? Those are decreases in medication. So it actually, you know, you should flip it in your head because that means that those folks could also cut their medication by a marked amount. And that's significant. At 24 months post-implant, DBS therapy along with medication improved quality of life all the way across the board. All the way across the board. And that, at the end of the day, is what's most important, the quality of life. It provided additional hours of on time without dyskinesia, so that's super important. Again, baseline is the green, dark blue to be consistent is deep brain stimulation. So they're on, they're feeling better, they're moving better, they're just living better with deep brain stimulation than at their baseline with medication alone. And so it improved a 30% significant reduction in that off time compared to 2% with medication at 24 months, and an additional reduction of 2.9 hours a day of off time, or a 49.9% reduction. I mean, you can't, if I had another 49.9% of my day, or 2.9 hours in my day, so I was at like 27 hours, you know what I could get done? All the things that I can't get done every day. That's what deep brain stimulation helps folks with Parkinson's do. And again, here's just another quality of life. Like, I can't emphasize enough that quality of life just is better. Quality of life, quantity of life, complications from Parkinson's, they're all better. It improves activities of daily living, baseline and at 24 months, and it reduced medications. And just in the interest of time, it also reduced drug-related complications. That seems like it makes a lot of sense, right? You're taking less medications, so you have fewer complications. It also gives you a bigger window. So if you can pull back your medication, remember we had that threshold for dyskinesias and side effects, you can pull it back to what it was 10 years ago or 12 years ago. It gives you a lot of time because deep brain stimulation doesn't cure Parkinson's, but it does work like lifelong. So it gives you a bigger window to add meds back in that were causing you problems before. So when, in summary, do you consider, well, a diagnosis or at least symptoms for 4 years it's responsive to that carbidopa-levodopa combination, or it's tremor that doesn't respond. We don't care. We can fix tremor with deep brain stimulation. And you're starting to have dyskinesias or motor fluctuations for a minimum of about 4 months or longer before we implant. And so those are the references. They'll be up there. And so now we want to open this up to questions. Before we open up to questions, I just want to say, every single victory counts, right? Every single thing that you do counts towards having a better life. Exercise, attitude, strategy, involvement. In my case, what I'm here to help you with is surgery. But no matter what it is that you choose to do, you make a choice to live well today and every day. And don't forget, even the smallest victory is the biggest victory. So thank you.
Great, thank you so much to all of the speakers. That was extremely informative. And we do have a lot of questions, and I think we will receive several more as we move along here. So the first question that came in is by a guest who says, I have cochlear implants. Is DBS doable? Must you have an MRI or are CT scans sufficient?
It can be very difficult, and it's surgeon dependent. Ideally, it would be an MRI, because the way that we choose the spot in the brain is based upon some structures and some known anatomic variants from those structures and some measurements that we take in your own brain. I have done 1 or 2 deep brain stimulation procedures with patients who could not have MRIs. They were difficult. And so in those patients, because I'm an ethicist, it was, look, we have no other option. We can try this, but we may not find the spot. You may be undertaking this risk to not find this spot. And so the most ideal, and there are some surgeons who simply say, absolutely not, you must be able to have an MRI. However, with very, very, very rare exception, some surgeons, and I don't want to speak for my other colleagues, might be willing to consider placing with a CT depending on how good the image quality is.
Thank you. This guest says, I know someone who started to show Parkinson's disease symptoms after using it's eye drops for glaucoma. I can't pronounce it. Is it possible that could cause Parkinson's?
I don't have any data on that. I've never read a study on that. I'm going to suspect that more likely the symptoms were there and subtle and became more evident. They can become evident, as Jim said, like in a stressful situation. He probably had those symptoms, or many of them, but you don't think about it, or they're very mild, but then you sort of reach a threshold and you fall off. So while there are some associations with chemical pesticide type exposures way back in the day and that kind of thing, they're very loose, and so I'm not aware of that one in particular, and I suspect it was probably more likely that, being hyper aware of some things, you become hyper aware, or you've reached a point at which symptoms become more obvious. That's my thought, not knowing somebody and not being terribly aware of that.
Oh, here's a guest that says, my mom had DBS. Dementia immediately ensued. It is not always a positive outcome.
Right, so that's where I talked about that neuropsychological evaluation being absolutely critical. The cutoff is a moderate to severe dementia, and so when DBS is evaluated appropriately, one would actually undergo a very rigorous neuropsychological evaluation. If mild cognitive decline was indicated, or even mild to moderate, there are 2 strategies. One is to stage doing 1 lead and then another lead. The other strategy would be to use GPI instead of STN, which doesn't allow as much medication reduction, but does allow us to implant slightly safer. It's gentler on the brain. But there is no question that if somebody has a moderate dementia and undergoes deep brain stimulation, there is a risk of worsening the cognitive side effects. That's why I say appropriate evaluation, including and critically including neuropsych evaluations, are important because we can make people worse with deep brain stimulation in certain settings. And I don't know about you, but I'm just not out there to make people worse. Just because I can doesn't mean I should. And so that's why it's so critical to really understand what the neuropsychological profile is and make a very, very careful decision when you start to head into cognitive decline.
Thank you. I had several questions about the device itself, and one of which is, can you kind of just show us it, and can you demonstrate how to charge this device?
Sure. This is the charger. They call it it's like a hockey puck. It's about that size. And it comes with a harness that you can put it in the harness. I can never get it in. I don't use the harness as much as I probably should. I just lay back while I'm resting. And when you're on the right spot, it'll tell you by stopping the beep. And then when you're fully charged, and I haven't charged for a week, so it's going to be a while, but when you're fully charged, it beeps a different beep, and you'll know that you're done. And then it comes with a device like this, which is like a TV remote almost. I have to hide it from my wife, because when she gets angry at me, I don't want her to know where this is. But I can literally turn myself off entirely, or I can adjust the stimulation on either side or both sides within limits. Can I have that? No.
Wonderful. That is great. And also, we've had the question is, what is the implant made of? Do you do any allergy testing or anything about, the makeup of the device itself?
We don't. So the device has silastic and typically a titanium non-ferromagnetic coat.
Sorry.
So these devices are MRI compatible or MRI conditional is what we would say. So as long as there's electrical integrity, there's no break in the device, then devices implanted today are typically MRI conditional, so you could have MRIs. I have never, not once, and I've been doing deep brain stimulation in private practice for 12 years. You add my fellowship at the Cleveland Clinic and then my residency. I started my residency in 2005, and we were implanting DBS back then. So in all that time, I've not once had a patient have an allergy to any of the implants. These are the same that are used in spinal cord stimulators and other implanted devices in the body. But we don't do testing unless somebody came and said, oh, I have a whole bunch of sort of allergies, but I'm not really sure what testing one could do other than taping it to their skin to see if they have a reaction. But there shouldn't be reactive materials.
I have a guest here. We're sad to say that his dad died from PSP, progressive palsy. And could something like DBS have helped?
No. And so that's when I say it's very important to understand your actual diagnosis. There's this umbrella of diagnoses called Parkinsonism. Parkinsonism is nothing more than people who tremor, stiffness, and slowness. Under Parkinsonism, there's Parkinson's disease, that's the vast majority, and then there are a whole bunch of other disease states, PSP, MSA, I could list an alphabet soup of other, Lewy body dementia, alphabet soup of other things that fall under this umbrella of Parkinsonism. Deep brain stimulation is for idiopathic Parkinson's disease. All those others actually can be worsened with deep brain stimulation. And the reason that we wait for that 4-year time period. We're shortening it down to 2 years sometimes with some of the studies that Dr. Charles out of Vanderbilt is looking at, et cetera. But the reason we wait that time period is because those other Parkinsonisms will usually rear their ugly head and progress faster and show other things, like for instance in PSP, eye movement abnormalities that would let us know. So we want to exclude those and make sure that we're only implanting folks that we can help and not worsen.
Exactly. There were a couple of questions about Lewy body disease. And is this appropriate with a Lewy body diagnosis?
Same thing. It's one of those Parkinsonisms, unfortunately, that progresses more rapidly, that has that dementia piece, which in and of itself would be an excluder.
A question for Scott. Have you had DBS and would you consider having it?
I have not had DBS. I would consider having it. I have a voicemail in my phone right now from the Medical University of South Carolina asking me when I'm coming in to be evaluated to see if I'm a candidate for DBS. And I'll tell you, part of that has, that's a result really of this journey that Jim and I are making. I've learned from watching Jim. I've learned from my association with Boston Scientific just how far DBS has advanced in the past few years. And it's increased my confidence a lot. And so it's under consideration.
Excellent. Can we talk a minute about cost and insurance coverage?
So it is covered by Medicare and it is FDA approved. There are about 1.6 billion different insurance, that's an exact number, right? Billion different insurance plans and types of coverage. And so what typically would happen is you would be evaluated, and then if you're found to be a candidate, it would get submitted to your insurance. Again, covered by Medicare, approved by the FDA, and so if you have a team that really knows what they're doing, you can get it approved. Not only that, but I have yet to have a patient come through who's been approved who has had an out-of-pocket expense that was exorbitant, and so this was affordable. But again, my brain can only hold, it's pea-sized, and it can only hold so much, and it cannot hold all the insurance information. But we have specialists. Our offices are set up to sort of push that through, and if an insurance pushes back with me, then I fight back, and I fight for my patient because that's the right thing. If I think this is the right thing and the patient is on board and says this is the right thing, what do you have to argue with? We have FDA approval, it's been around for 30 years, it's safe, it's not experimental, and so I really don't find it to be an impediment, but could I tell you how much it costs each separate person? I couldn't off the top of my head, if I'm being honest.
Right. How often do you charge your DBS?
I charge mine about every week or week and a half, unless I'm traveling. I've gone as long as about 3 weeks, and even still, the charger indicates that I'm fully charged, so it'll last for quite a while.
And does that vary from patient to patient?
Yes.
Do you think?
It does. It varies from patient to patient, and so that's one of the advances. We've had rechargeable deep brain stimulation for quite a long time, but one of the advances with the Boston Scientific Vercise generator in particular is that charging interval is very long. So it allows you to keep a generator for a long time. I mean, 15 years is like a crazy. We used to have to change generators every 3 to 5 years, and every time you have surgery, there's a risk of infection, et cetera. Now that you can maintain a generator that gets you 15 years, I mean, I'll be honest, I'm probably going to be retired in 15 years. I've been at this a long time, right? It might be the next person changing that generator. But that's an advancement. And the other advancement is that long charging interval. It used to be that you had to charge every day with different charging devices. And so this advance in this generator is just breathtaking. But if you're using more energy, if your voltage is high, you're using more energy, you may have to recharge sooner. And then the strategies are different. You recharge when you need to. Some people find that it's just easier to recharge every night for 10 or 15 minutes while they're sitting watching the evening news, and that way they never forget. the beauty of it is it allows people who, for instance, you could travel to Europe and you don't have to worry about charging on some weird system, even though they have adapters, etc. You can go on your week-long vacation if you're topped up. So there are a lot of different, it allows people to have a lifestyle that they could not have before when they had to charge every day, and it allows them to go much longer without surgery, which decreases infection rates and overall increases quality of life. So I think it's a huge advance to have a generator that does that.
Right. Can you remind me again, do I need to make an appointment with you or someone in your profession through my provider, my primary?
So you can just call my office and make an appointment. We pretty much take every insurance out there. There's like one or two like little strange ones that are newer that we may not be on, but I'm happy to see anybody. Obviously, if you have a movement disorder neurologist, the best place to go is to start with them and say, hey, is deep brain stimulation right for me? Am I at that place? And movement disorder neurologists who have a fellowship in movement disorders, they know about DBS. Like I said, it's been around forever. They know about it. Most of them are big fans, and so they're going to push you. But if somebody says, I don't think it's for you, and you don't quite buy into that, it never hurts to sit down with a surgeon. Or you say, maybe I'm not quite ready. It never hurts. I talk to people and say, yeah, it might not be for me, but my doc said I should call you. So you can call my office and you can make an appointment with me. I would love it if you have a referral from your neurologist, but if you don't, that's okay. There's lots of people out there who have Parkinson's that are treated not by neurology. And so they're treated by family practice and they don't know as much. Not that they're not great docs, but they have to know everything about everything, right? And so they say, I don't know that much about DBS, so I'm not sure. So I'm happy to talk to anyone. This is my passion. This is what I love to do. I do all the other stuff, brain tumors, spine surgery, etc. I do all of that to allow me to do this thing, which is really help people with movement disorders, Parkinson's and essential tremor, but Parkinson's talking today, live a better life. And so I'll talk your ear off. I have to watch myself in the interest of time, right? And shut up about it because it's such an amazing, life-altering therapy, and it's something I believe in to the bottom of my heart. So call my office, make an appointment, call your movement disorder neurologist, ask them about it. Your job in life, no matter what you do, is to be your own advocate. You've got to speak up for yourself, and maybe they'll say, you're not quite there yet. I tell people all the time, it's not quite the time for you, or this isn't quite right for you. But I'd rather you ask me than get to that point where it's not an option anymore. Or, I wish I'd done it sooner. Gosh, why didn't I know? So advocate for yourself. That's important.
Exactly. We have a question here or a comment from a guest that says, I was diagnosed 3 months ago. My symptoms are still very mild. Should I wait before considering DBS?
So remember we talked about deep brain stimulation and you really needing to have a diagnosis for a few years and optimize your medical therapy and ensure that you really have Parkinson's and all of those things. So the best step to do if you have a new diagnosis is number one, as they talked about, connect yourself to the community. You have so many options in the community. Young onset Parkinson's, early diagnosis Parkinson's, you have support groups, you have exercise classes, and then really have a good conversation. It's not too early to end up in a movement disorder neurologist's office. It's not just folks with moderate to advanced Parkinson's that show up in movement disorder neurologist offices. Start early. Again, advocate for yourself. But it is, at this point, a little early for deep brain stimulation.
Right.
I would also add that Boston Scientific has an incredible website, dbsandme.com, that if you're just starting to have questions or whatever, go on the website and take a look. And that'll answer a lot of basic questions that you might have. It certainly doesn't serve as the alternative to an educated doctor's decision or information, but it's certainly a place to start.
Thank you so much. And I would remind our viewers that we do have time for some more questions. I have about 3 left here, so go ahead and type your question in the chat box if you, unless they've all been answered, and let us know if you have some more questions. So talk to me a little bit more about when is it too late for it to be an effective treatment?
Again, it is too late if medication is no longer effective, with the exception of tremor. So tremor just gets better. But when those medications no longer give you an effect, then it is too late. So that's that United Parkinson's Disease Rating Scale, UPDRS, motor subscore. When you have less than a 30% improvement, irrespective of that tremor, then it may be too late. The other one that it is definitively too late is that moderate to severe dementia. That's where we can make things worse. And so that's why that window is so important, and that's why we're looking at, how early is it, how safe is it to do early? There are ongoing studies at Vandy and other places where we're looking at, is it safe? And within about 2 years of diagnosis now, some of the data shows that may be safe, that we've sort of filtered all those other things out and it may be safe. But it is decidedly too late when medication doesn't work. I'm going to wait until nothing else works. Well, this won't work either because it's working in that same region, and then I'm going to wait, and then somebody develops a dementia. Then it's too late. And so that's where it's heartbreaking to me, because if they come in even 6 months, a year earlier, would have been implanted, yes, they would have moved on to their cognitive decline, just like everything else. However, they would then have the stimulation safely, and it would continue to work lifelong.
Thank you. A viewer does ask, what do you mean by off hours? Is the stimulation turned on for only certain hours per day?
You leave the stimulation on the whole time. What we mean by on and off is really referring to medication. And so when you're on and your medication is working, you have less tremor, you have less stiffness, you have less slowness, you are moving better. That's considered the on state. The off state is where that medication wears off, hence the name off state, and that's where you're stiffer, you're slower, you have more fatigue, you have more tremor. And so deep brain stimulation doesn't take away all of the off time, it reduces it again by about 49.9% is I think the number that was in the study, or adds an additional 2.8 hours of on time a day. So on-off is not about the electricity. I think that can be a little bit confusing, right? The electricity is on. That is stimulating your brain. It's really, are you getting effect? And so it relates back to that medication, whether it's working or working less, but it's always on. 24 hours a day, 7 days a week.
I might add to that on and off, and I think Jim can probably relate to this. If you've had Parkinson's disease for a while, you can call it whatever you want, but I can literally tell you the time of day by the way my body feels. These guys that travel with us on our trip, Parkinson's Across America, they get tired of me saying, man, it's time for me to take my medication because my tremor starts presenting. I'll take my medication, my tremor goes away. And as the disease has progressed, my period of effectiveness, or the on time, has lessened, which is common. And I think you could relate to that same.
Absolutely, absolutely.
And then riding your bike gives you more on time.
Riding my bike.
There is zero question that
No
riding
doubt.
your bike gives you more on time.
My tremor goes away when I ride my bike.
It's amazing. It's incredible how much exercise, and that's the key. So that's the thing that is so important to me, and my message to you, I'm sure your surgeon told you. It really is, you went through the risk, which is small, and you went through the process, which has been beneficial, but now
Why waste it?
get on the bike.
Sure.
Do yoga, do rock steady boxing, go to dance for PD, get moving, because now you move better. I keep pointing at you like I'm lecturing you to do it, but I am.
But it's true.
I really am. Like,
so
that's
true.
the key, is get
He
moving.
needs lectured.
Well, that's great, and I just want to say one more time, Parkinson's Across America. Our viewers can find that. ParkinsonsAcrossAmerica.com.
Again,
Yeah.
PDAcrossamerica.com.
Instagram, Facebook, and Twitter.
pdacrossamerica.com.
These gentlemen are awesome. I
Yeah.
can't tell you how amazing they are, how inspiring they are. I want to thank you from the bottom of my heart for sharing a bit of your story and your day with me today.
Thanks for
Thank
allowing
you.
us to be here.
Thank you.
It's a privilege.
Yeah. I think we all feel that way. We feel very blessed to have your knowledge and your expertise in sharing your story with us. So I have a couple of people that have asked, can you have this, I guess DBS, if you have a pacemaker?
Yes, absolutely. Oftentimes we'll put it on the opposite side of the pacemaker. It has to be a certain distance away from the other generator so that there's not electrical crosstalk, but absolutely.
If a person already has a DBS system, can new advances in the technology help them? And can you mix systems?
You can. You can mix systems, so you can take older leads and put them with newer generators. You can take one company's lead and place it with a generator that might provide some more relief, have better programming. And so, for instance, there are a lot of systems out there that, you know, I've had DBS for 20 years, but I really want this new advance in programming. I want to be able to do these special things. So the next time your generator is up for replacement, you can swap systems. And there are some surgeons who find that to be problematic, but many surgeons who are doing that swap because they find that they're getting better results with a different generator. And so that is something that absolutely can be done. The leads are a different story. The leads are the brain part, right? And if they're in the right spot and they're not broken, what's not broken you don't fix. You leave the lead in place, and then you can play around with the generator, which honestly, outside of directional leads or multiple independent current control, really the advances, the stuff that's going to come along that we can do with DBS is really going to be at the battery or the generator level. So yes, you can get new generators that are more advanced. You can do hybrid systems. You can do some of those things to optimize your outcome. Because again, you got to be your own advocate and you got to do what's best for you.
Absolutely. We have a couple more questions, unless a couple more come in. This next to last one is, how do you know which device is the best one to use? How do you know?
So some of that, it can be a little bit difficult. So ultimately, the person who does your programming is really more important than the surgeon. I can put any device in anywhere, like that's at the end of the day. And I have very strong opinions about which devices work best. But if I'm not going to be the person programming it, and the person programming it doesn't know how to use the company, and there are three big companies out there, doesn't use that company, well then I can put something in, but they can't use it. I can do it, I can help you, but so some of it is the neurologist, who is typically the programmer. Most neurosurgeons don't program in their office, although I do. And then the second is what characteristics do the devices have? And so I think that segmented leads that have a segmentation to them, are superior to the old ring mode leads. So without question, in Parkinson's, a segmented lead is a lead that needs to happen. I feel very strongly that multiple independent current control is incredibly important, so that now I have these segments, I can ensure that the electricity going to these segments is the right electricity, the right amount, the right time. And then it comes down to what generator qualities are present. And different folks have different philosophies. I personally find that being able to use MICC, so that multiple independent current control, with a generator that has a very long recharging interval and a lot of mobility on the programming, is what's best for my patients. There are other systems out there that have other bells and whistles. In my opinion, I just don't find them to be as helpful. And so this is not a sales pitch for Boston Scientific, but I implant the vast majority of my patients when I am given the choice with Boston Scientific. If I'm not given the choice, then I'll implant, a neurologist says, this is what I want in my patient. It's also a conversation with the patient. You know, you say, hey, take rechargeable generators, for instance. There are some folks who say, like, I can't even work my flip phone, much less like this whole stuff and recharging, or I go to Africa for like, you know, I'm in sub-Saharan Africa doing missions for like 3 or 4 months and I need to be able to have this. Those folks might not want a rechargeable battery. So it's a complex question because it really comes down to what does your neurologist feel is the best, what do you feel is the best, what does your surgeon feel is the best, and what criteria and qualities work best for you and your life and what you have. And there's a lot of different philosophies out there. Again, I'm not advocating for one company over another. I think it's a conversation. At the end of the day, as an ethicist, it's a conversation. But I've been very clear about sort of what I tend to implant in the Parkinson's setting.
For me, the variability in programming was important. And it turns out that that's been the case because my right lead is just outside of the STN on that side, just a little spot. And with the image-guided technology that Boston Scientific has, we've been able to see how that stimulation can be redirected in a way that hits just that part that's inside of the STN. And I think that that's made the difference in the world for me. So I've been very, very happy. And I love the rechargeable also because it's a smaller device. And, you know, I don't know if you could feel the larger non-rechargeable one more, but certainly I prefer the rechargeability.
Thank you. So are there specific exercises you'd suggest? I walk 3 miles a day. I also do MYMBYL, which I'm not sure what that is. Anyway, so I know you've talked about the cycling and the boxing, and so are there any specific?
In my mind, it's what you enjoy doing and what you're going to get out and do, because it's the continuity and the continued activity on it, doing something at least on a daily basis is necessary, I feel, to make a difference in your, you know, the really enjoying the benefit of the exercise. Scott, what do you?
The only thing I would add to that is do something that's challenging. I mentioned earlier getting your heart rate up. I'm told by all the experts that's important. And I think it's easy to fall into the trap of doing something that's comfortable. Challenge yourself.
Right.
I think that's critically important. The best data out there is on cycling. However, there is a ton of data for all kinds of movement. It's getting your heart rate up. It's doing something you love so that you'll do it consistently. If you say to yourself, I would rather shove bamboo under my fingernails than do X, then don't do that just because they say do X. Pick something else that you love. There are plenty, the reason that we keep talking about dance for Parkinson's, pedal for Parkinson's, rock steady boxing, are because these are very specific and they're really well done for folks with specific issues with Parkinson's, like balance. Dance for PD, amazing for balance, right? And spectacular and fun. But if you hate dancing, it's probably not going to be you. Go to rock steady boxing instead, right?
Exactly.
Well said.
Exactly. Well, we're so thrilled that for this presentation today, and I know that, and I know all of our guests also are very grateful for all of your information, and they'll check out and follow you as you go across the country with your wonderful mission. And so, on behalf, though, of Boulder Community Health, we do thank you again for joining us, and a recording of today's lecture will be available. It's been recorded, and it'll be available at bch.org/livestream in a couple of days. And so if you want to send notice to your friends and family that it's available to watch in a couple of days. You can go to BCH website and find a recording of this lecture and review it again. You'll also receive a post-lecture survey by email, so please take a minute to fill this out. And if you have any other questions, just let BCH.org know. And thank you very much again to our speakers, and thank you to our audience, and thank you for joining us today, and have a great afternoon.